Welcome to everybody. We're very pleased to have Dr. Henry Ginsburg speaking to us tonight on lipoprotein little a, who should be tested and why. Dr. Ginsburg probably doesn't need any introduction, but he is the Irving Professor of Medicine at the Vagelos College of Physicians and Surgeons at Columbia. He's the Associate Dean for Clinical and Translational Research at Columbia University Medical Center in New York. He's the author of the recent AHA scientific statement on Lp(a), and he has received multiple grants from the NIH, authored hundreds of papers, but mostly I think that what you'll find is Henry is just a wonderful person. I've known him for the last 30 years, and he's a great teacher. He's a wonderful mentor, and I think we're all in for a real treat this evening. And I am Mary McGowan, the Chief Medical Officer of the Family Heart Foundation. Next slide. Just a few housekeeping things. This is not medical advice. This webinar is for your information, so it shouldn't be construed as professional medical advice, diagnosis, or treatment. It does not constitute medical or other professional advice. Medical information changes constantly, and the information on this webinar could be updated at some point. Please follow up with your physician and medical team for your specific recommendations pertaining to a treatment for you and your family. Next slide. I'd like everybody to say hello in the chat, introduce yourself, and make sure we know who you are, where you come from. Make sure you change the chat settings to everyone so we can all meet you rather than just the panelists. Next slide. And if you have a question, we would request that you put it in the Q&A, and I'll keep track of that over the course of Dr. Ginsburg's lecture, and we'll get to those questions at the end of the session. We want to thank our sponsors for Lp(a) Awareness Day, Lp(a) Awareness Day, which was just March 24th. Our champion level sponsor was Novartis. Our partner level sponsor was Amgen. And then our Community in Action team, foundation level sponsors, Amgen and Novartis, community level, Konica Medical Products and Silence Therapeutics. And thank you to all of you who are our Family Heart partners who donate generously. Thank you. And now I'll turn it over to Dr. Ginsburg.
Hi, everyone, and thank you, Mary. You put a lot of pressure on me. You look like a nice person. And like most speakers, I would start off by saying it's a pleasure to be here, but actually, it's not such a pleasure to be here because I wish there was no such thing as lipoprotein A, and that I wouldn't have to be here telling you about it. And many of you are here because your lipoprotein A is high, and I'm sorry for that. But we do need, because it does exist, because it's important, and because it's been in the shadows for so long, we need to have programs like this to try to at least spread the word to interested parties, and also to confirm what you thought you knew, possibly to bring new information to you and de-confuse you about certain issues. So let's just move ahead then. Next slide. This is why you should measure everyone's LPA if you're a physician, or this is why everyone's LPA should be measured by the health profession. This is a patient that I've known for a long time, a 50-year-old male when the case started, an LDL cholesterol of 120. That's below the average for adult Americans, not considered to be harmful, which is not true, but not considered to be treatable by most physicians. HDL 75, not low, and nowadays not too high. A triglyceride, that's super good. Blood pressure, that's fine. A hemoglobin A1C, that's fine. BMI, a little bit overweight on the edge. Family history of aortic stenosis and peripheral arterial disease in this patient's father when the father was in his late 60s. The patient was a lifelong runner and never smoked. And at the age of 50, serendipitously, this individual had a coronary calcium score, and it was 20, which put him into the 90th percentile for his age. And the site was the proximal left anterior descending artery, the so-called widowmaker portion of that artery, the second largest coronary artery outside of the main coronary artery. And a stress test followed. He, as a runner, was able to go 12 minutes, and it was a negative test. Next, please. So what followed was a lipoprotein A, not very commonly obtained, but it was, fortunately, and it was high, 175 nanomole per liter, somewhere above the 90th percentile for this individual. So statins were started, and for many, many years after that, LDL cholesterol was between 60 and 70 milligrams per deciliter, and no change in lipoprotein A. With that, over the next many years, the patient had repeat stress tests every several years, which were normal. More recently, exercised on an elliptical, 40 minutes, 3 or 4 times a week, working very hard with a heart rate up to the 150s. Next, please. So what is this lipoprotein A? And it's pronounced as I just did. It also can be called lipoprotein little a, and or LP, short for lipoprotein little a. It was discovered, amazingly discovered, in 1963, so 60 years ago, and by someone named Kari Berg, a Norwegian immunologist who was looking for new proteins that were associated with LDL cholesterol. He shortly showed that this problem was a genetic trait and called it lipoprotein A. Next. So what is LDL? And this is an error on my part. It should have said, what is lipoprotein A or LPA? Next, please. This is a build slide. It is not LDL. And everyone knows about LDL. And this is a great cartoon of an LDL. And I'd like you just all imagine that there are these submicroscopic golf balls circulating in your bloodstream. They have a coating of something you've probably never heard of called phospholipid. They have some proteins on them, and a key protein is called ApoB100. And inside, in the core of the little golf ball, are cholesterol molecules, mostly what we call cholesterol ester molecules, and a little bit of triglyceride, real fat. And so this is the well-known bad LDL cholesterol, or the bad cholesterol carrier package in the bloodstream. So let's, next slide, please. This is just a different version of that LDL that I showed you. And next slide, this is what LPA looks like. Mostly, it looks very much like LDL, but it has the extra protein, this little a protein, shown here as those little 6-sided designs and a bunch of sort of beads connected to each other, almost like a necklace. And it is attached to that ApoB100 protein at a certain specific point. Next, please. And so the presence of ApoA or ApoA makes LDL very different from LPA, and LPA very different from LDL. And we'll talk a little bit about that, but not much in the weeds. Just they are very different because of that extra protein. Next, please. So what is the origin of ApoA? Where does it come from? Well, there's a protein that we all have in our blood called plasminogen. And like every protein in our body, this protein plasminogen comes from a gene the plasminogen gene, and it's schematically shown here with different pieces of DNA strung together in a chain, and one's called K1, K2, K3, there's a K4, a K5. And then there's a P area, which stands for protease. So this plasminogen is a critical actual protein in all our bodies because it can be activated by other chemicals and turned into a protein called plasmin, which breaks down clots. So anytime you have a clot, let's say you form a clot, unfortunately, inside your coronary arteries, the clot needs to be broken down some way, and the body immediately starts to break it down by converting plasminogen to plasma. So what has this got to do with LP little a or apo little a? Next, please. This just points out that protease domain that I said, the P domain, is what actually is the active piece of the protein that breaks down plasmin. Next. So here's where plasminogen and lipoprotein A or LPA merge in a way. And somewhere during evolution, the plasminogen lost about half of its DNA pieces, the K1, K2, K3. So all that remained were K4, K5 in the protease domain. And then further along in evolution, the K4 turned itself into 10 different types of K4, each with some differences in the DNA bases that make up DNA, and therefore get translated to, over time, to a protein. Finally, to make things most complicated, sorry to say, but a very important complication, this K4-2, the second from the left, duplicated itself in an identical manner, anywhere from 20 to 30 to 40 times. And so all of us have two different genes, one from each parent, and I'll get back to that in a little while, for apo little a, but we all have different versions from each other. And the two versions we have are usually different because there are 40 possible differences. Obviously, some of us have the same version, but there are so many different combinations that were all very different. And the protein, next please, very importantly, the P domain, that protease domain, lost its activity, another action of change in DNA during evolution. And this means that this apo little a, which has very many similarities to plasminogen, has one big difference. It can't break down fibrin. And so it's not good at all to help you break down clots. But there's a theoretical possibility that the apo little a can bind to a clot and block plasminogen from binding because it's got all those other similarities. And therefore, that LPA or ApoA itself can be pro-clot, that it would inhibit the body's ability to break down a clot in an artery. Next, please. So after his first paper, Dr. Berg quickly showed that this was highly heritable, ran in families. A few years by the mid-1970s, he and others in Europe, it was much more popularly studied in Europe than in the US, found links of high levels of LPA to the risk of coronary artery disease. By 10 years later, with better assays, LPA levels were found to be associated with all types of cardiovascular disease, stroke, coronary artery disease, peripheral vascular disease, and across a range of values. And importantly, as I said, that little a protein sitting on what otherwise looks like an LDL made a big difference because unlike LDL, LPA was not sensitive to diet, to the environment, or to the available drugs, and that's remained pretty much true when we get to that later, to lower LDL. And in 1987, the apo little a gene was cloned and sequenced, and that's what I showed you on the prior slide. Next, please. So why didn't you know anything about it, or why didn't any of us, except a few people in the tiny little field of LPA science, why didn't anybody know about it? Why don't most people still not know about Lp(a) and its role in atherosclerotic cardiovascular disease? Next. So it's one of the reasons is that to really know a lot about something, you have to be able to measure it easily and measure it in a very sensitive and specific and reproducible way. And for years, that the assays that were there were not very good. They're not perfect yet, but they're getting very close. And even though they're not perfect, they are certainly good enough to know who has a very normal Lpa and who has a very high Lpa. And we'll get back to that as well. Next. There were very few animal models. There were very few cell models. So scientists have had a tough time measuring Lpa, measuring its actions or characterizing and defining what Lpa does, how an LDL and an ApoA get together, what it's doing in plasma, why it's pro-atherosclerotic. And then also, the focus for the field of heart disease and cardiovascular disease has been LDL cholesterol for 50 years. And it's been hard to break through and point out that there are other factors carrying lipids, other packages carrying lipids besides LDL that might be important, and Lpa being one of those. And this problem was made worse by the fact that people in the field of public health and in the clinical field in the health professions were really focused on LDL cholesterol. But as I showed you very early, Lpa also has cholesterol as its major lipid, and they get measured together in all the clinical assays that measure cholesterol. They're measuring LDL cholesterol and Lpa cholesterol, and separating those two has been very difficult. And there are some assays that are coming along that will do that as well. So things are getting better. Next. Okay. Finally, if you heard about Lpa, there was a controversy about its importance relative to LDL. Many people felt there was a small player in atherosclerosis. Many other people, including myself, feel that it's at least as important as LDL. And per particle, per golf ball, each Lpa might be more atherogenic, more likely to cause atherosclerosis than a single LDL particle. Next. But most importantly, health professionals, particularly physicians, don't think about and don't want to hear about something they cannot treat easily. So they don't want to measure something because if it's bad, they have to tell the patient there's nothing they can do. And of course, that is incorrect. Next, please. So some questions and answers. Can we trust Lpa assays? As I said, they're good enough right now to let us know who's got a problem and who doesn't. And I'll talk about where that defining point of a level is. Next. How do we explain Lpa assays that might be in milligram per deciliter or nanomoles per liter? This is a bit in the weeds, but you have to deal with it. And so many of us have had patients who get a lab test for Lpa with milligram per deciliter, and the next time the lab, or they go to a different lab and it comes back nanomoles per liter, and it's dramatically different. And so the assays now are able to convert back and forth to some degree, and there was a general consensus, and now probably not such a general consensus anymore. We're always changing rapidly in science. But I would say in general, if you have milligram per deciliter and you multiply it by 2 or a little more, you'll know what it's going to be in nanomoles per liter. But as I said, for instance, if you had a level of 50 milligram per deciliter, and the next time you had the blood tested, it went to a different lab and they came back with 120 nanomoles per liter, you'd call me up and you would say, what happened? Am I going to die? My Lpa level more than doubled. And I'd say, no, you have a different assay. Just look at that, the little letters that come after the Lpa concentration. So we're gonna get through this area of problem in the next few years, and we'll all have 1 or 2 really nearly perfect assays. Next, please. This just actually shows that the 2 ways of describing the concentration are highly related. They're highly correlated. Next, please. How often do I have to measure my LPA? Well, unless you're given a drug that has some effect on levels, you only have to measure it once. It is stable from age about 2 years throughout life. Possibly or probably women postmenopausally have a modest or moderate elevation in LPA, not from a normal level to a very high level, but it will possibly go up. And so you might, when you reach that age, a woman reaching the postmenopausal period and having had an LPA done 10 or 15 years before that, they might want to repeat it to see where it is. But again, it's not going to start at, let's say, 50 milligram per deciliter and then go through menopause and now it's 200. That's not going to happen. Next, please. The bottom line again is everybody should have it measured at least once. Next. And this is my disclaimer. This is not recommended by the two largest cardiovascular institutions that we deal with all the time, AHA and ACC. It is a recommendation of the European community and the Canadian cardiovascular community. Hopefully the next time AHA and ACC come out with guidelines, they will say that everyone should have this measured at least once. So again, let's go back to the molecule and a little bit more science. The K4-2 that I focused on, and the fact that there are so many of them possible and so many varieties. We all have different flavors for our Lp(a) because of the varying number of K4-2s. What does that actually mean? Why is it important? Next, please. Well, they're very important. Next, please. So here's a very nice slide by Sam Tsimikas and colleagues looking at 4 different people who have each inherited from their parents. You get one gene, we have pairs of chromosomes, so we have pairs of every gene, one from a parent, one from the mother, one from a father. And the mother and father are very likely to have in their 2 genes apiece very different K4 numbers. And so this just shows you there's up in the upper left, there are 4 K4-2 repeats. The upper right, there are 8. The lower left, they're 24. The lower right, they're 40. So we all are a composite of 2 or more of 2 different numerical repeats of K4-2, and therefore we almost all of us are what we call heterozygotes for LPA. We have 2 different forms. There's a question, I guess, that popped up, and I'll just mention it now. I'll get back to it later. Is this a dominant or a recessive or a co-dominant inheritance? And if you don't know the terms, we'll talk about it more later. It looks like that there's some dominance here, and I'll get back to it in the next few slides and we get into this in more detail. Next, please. Yeah. So, wow, lightning struck this slide. Okay, just look at the green, red on the lower left and the bottom of each panel. I don't know what happened to the rest of the slide. Now just go back for a minute. One back. Okay. So LPA, most biological measurements that we make, height, weight, blood sugar, even LDL cholesterol, fall under the nomenclature of the bell-shaped curve that you've all heard about one time in your life or not. And if you look at the green mountain, very narrow peak on the left of each panel, you will see that it looks like not quite a bell, but it's symmetrical. But then when you look where it turns red, there's this long tail. So about 50% of people have very low, well, 50 to 70% of the population has relatively low levels of LPA. And the top 20 to 30% have a wide spread going from moderately elevated to extreme elevations. The next slide makes the key point that your level of LPA to a great degree is determined by the number of the K42 repeats. Those repeats that can run from very low numbers, 1, 2, 3 repeats in an LPA, to very high numbers, 35 to 39 or 40, and everywhere in between. And the higher your number, the lower your level will be. And actually, LPA levels are about 90% inheritable or genetically regulated, where LDL is about 70% regulated. Therefore, LDL can be environmentally impacted, or many drugs that can impact it. LPA, about 90% genetically regulated. So very little wiggle room, certainly for the environmental approaches we've always used and preached about for LDL. And the Kringle-4-2 repeats make up about half of that genetic regulation. And then there are other variations in the DNA of ApoA that drive the rest of the genetic regulation. So that's why it's stable throughout life, because it's so highly dependent on the gene. And if you have one low number gene and for ApoA, and you have one high number gene for ApoA, one from each parent, you will unfortunately have a high LPA level. The low number ApoA forming a low number LPA, a low Kringle number LPA seems to dominate. The data are not 100% certain, but it looks that way from many studies. Next, please. And this just quickly shows you and these are studies done in Denmark, huge populations of people and terrific investigators, that what I've been saying, if you have low numbers of Kringles, 6 to 30, you have a very high level of LPA on the y-axis, and if you're up at the top level of Kringles, and the numbers here are larger than I said, and that's because in this assay, they add up both of the genes. So someone who's a 99 there at that last quartile, and maybe would have the highest level of K42s in both of their genes. But just the important point here is that there's this very strong relationship. Small numbers of K42s, very low levels, very high levels, large numbers of K42, very low levels. Next, please. Okay, and so what should we worry about? Well, this just looks at, on the left, percentiles in the population relating to the levels of LPA in the population. And on the right, something we call hazard ratios, so the risk for heart disease in these people, myocardial infarction, a heart attack. And it's pretty obvious that if you're at the top of each panel, the 95th percentile, and in this case, greater than 117 milligram per deciliter LPA, you look at where that black circle is compared to that dotted line and look at the bottom axis, you have almost a 3 times greater average chance of having a heart attack than somebody who has an LPA down under 5 milligram per deciliter. And then across the board, it's a stepwise increase. Next. Now, the levels that I just showed you are again in the middle of this slide, and to the right is a panel showing the K42 repeats. And you can see the importance of the K42 repeats. They parallel the levels, and they parallel the risk. So people with high levels will have small numbers of repeats, and they'll have increased risk. Next, please. This is the busiest slide, and only 2 points or so to make. One is, if you look at the left side, there are clear racial ethnic differences in the average LPA of a population. African Americans or Blacks have about 50% higher LPA levels. Asians, or at least in this population, Chinese, have somewhat lower levels. South Asians, somewhat in between Blacks and whites. So there are important differences. However, if you put, for each of those populations, you line people up by their LPA level, the line of Black individuals will have higher levels across the board, but when you get to the top 20%, their risk will be the same as the white line in the top 20%, or the Chinese line in the top 20%, or the South Asian line. So it's just not good to be at the top level of LPA, even though the numbers may differ. Next, please. And this just looks at LPA levels in almost 500,000 people who in something called the United Kingdom Biobank. And it just shows that the risk of LPA is a continuous risk. And next, please. That actually, every time using the nanomole per liter measurement, every time there's a 50 nanomole increase in risk in one individual versus another, their chance of having a heart attack over their life is increased by 10%. And that doesn't seem like that much, but I'll show you something in the next slide. Next, please. Yeah. So here, if for every 50 nanomoles per liter, your risk goes up about 10%, then about 11%, excuse me. Let's say you're someone who has already a relatively high risk, 10-year risk by the American Heart Association risk analyzer of 10%, 10% chance of having a cardiovascular event over 10 years. And that risk was not based on an LPA. It's based on LDL and age and HDL and blood pressure. And so now, what if that person is found to have an LPA of 250 nanomoles? Well, the bottom line is, go right across all those numbers and you see in the far right, 16.9. The risk for that individual over 10 years has gone from 10% to 16.9% now that we know more about that individual. That is, we know how high his or her LPA is. So it really needs to be added to the equation, and it needs to be measured by health professionals, and then there has to be a discussion about what to do. Next, please. And so I've done most of this already, but it just shows that what the different percentiles are in the population by the milligrams and nanomoles. I want to save more time for questions and answers. So next, please. So why should we measure it if we don't have treatments? And this, my disclaimer here is that AHA, ACC guidelines don't offer any advice on this, but not much, maybe a little. But what I say to my patients is, I don't have really great ways. I have a couple that I'll talk about briefly, but I don't have great ways to lower your LPA levels at this time. But I have ways to lower your LDL level quite dramatically. I have ways to treat blood pressure and make it better than average. I have ways to make sure your blood sugar is good. I make sure that your lifestyle is excellent. And anyone's risk of having heart disease depends on all of those factors and more that we're not even going to discuss. So you approach the patient very aggressively. Since I treat lipids, I take an LDL. If you have a high LPA of 250 nanomoles, 95th, 98th percentile, and your LDL is, like my patient, 120, that's not good enough. Even 90 might not be good enough. And I'd want to lower that significantly. Next, please. So what treatments lower LPA? Well, we start off with what doesn't lower LPA. Statins don't lower LPA, and it may rise a little bit, but on the whole, the benefit you get for lowering LDL with the statin outweighs by far the risk, maybe the risk of raising the LPA 10%. Ezetimibe has no effect on LPA levels. Niacin, a drug that's not used much anymore, can lower LPA 15 to 30%. PCSK9 inhibitors lower LPA levels 15 to 30%. Neither of those are approved by the FDA for LPA lowering. Of course, the PCSK9s lower LDL about 50%, so it's a 2-for-1. Niacin lowers LDL 15%, so it's much less potent on that point. And we have lipoprotein apheresis, which has FDA approval with some very strict guidelines of having a very high LPA and having an LDL over 100 milligram per deciliter despite aggressive treatment. But next, please. What's coming down the pike? Well, it's coming down the pike if the studies show prevention of cardiovascular events. What's coming down the pike is that we'll have drugs that'll wipe out LPA. They'll lower LPA by anywhere from 70 to 80 to 90, 95%. The first one will be available, hopefully, again, if the study that's ongoing by Novartis with their antisense oligonucleotide to lower LPA about 75 to 80%. If that reduces cardiovascular events in their population and gets approved by the FDA, it'll be available to some people in the population. There are 3 other companies that are a few years behind, but moving forward as rapidly as they can. And so I would say 5 to 8 years from now, we'll have more and more drugs that dramatically reduce LPA. And if they're there, that means they dramatically reduce cardiovascular risk. Next, please. So let's get back to this is why you should measure everyone's LPA. A 50-year-old who was found to have a coronary calcium score and a high LPA. So what happened to my patient over the next many years? Well, 25 years later, he noticed some funny sensation in his chest while on his elliptical, and ended up having a stress test, which didn't show ischemia, but had a lot of atrial premature contractures. He didn't feel well during the test, ended up getting an angiogram, and had subclinical, as we call it, but significant narrowing and heavily calcified stenotic lesions in his LAD, both proximally and in the middle of the artery. And so this person's physician added a PCSK9 inhibitor to the statin and took the LDL from that 60 to 70 range down to 25 milligram per deciliter. And the LPA came down quite dramatically. It came back up after this number, but it was down around 30% or so. And,
So Henry,
yes,
this is pretty dramatic. And but one thing I would point out here is it's pretty amazing that this person went for 25 years and did really beautifully, getting started on lots of other therapies, and in large part, really just therapies to lower the LDL because everything else was in very good shape. Can you tell us anything else about this patient?
Sure, Mary. Well, I think I just first would reiterate that this patient had no other risk factors.
Right.
Family history was a little bit with some possible risk.
Sure.
On both sides, but nothing that could be nailed down. And so you have to say that, you know, almost everybody in the world develops calcium in their coronaries, so certainly in the Western world as they get older. But this was quite a dramatic finding after 25 years with LDL levels where you shouldn't expect any coronary disease to develop. And
absolutely.
As to your question about the patient is me. And so I was lucky enough to have an interest in coronary calcium and a friend who was running them. And I was knowledgeable enough to know about LPA once I saw the coronary calcium score. And I was smart enough not to deny away a risk factor and take my LDL down. And I would say it is very possible that with a continuation of an LDL of 120 with my LPA, and not doing anything else, one of my bouts on the elliptical might have ended up tragically. Can't say
Yeah,
sure, but very likely.
and you know, I couldn't agree more, Henry. And I feel like you, as a physician, were lucky enough to have a friend who was starting a coronary calcium lab, and you know, serendipitously, you got tested. You wouldn't have had an indication to be tested, and yet you did, and so your point is so well taken. This drives home why everybody needs to have their lipoprotein(a) measured. And you gave a number of reasons earlier, but one of the reasons I would say, one of our previous LP(a) webinars, one of our advocates, Jenny Ray, she waited 18 hours with chest pain before seeking care. And she, this is a quote, she said, "I thought I was having a panic attack. If I'd known about my high LP(a), I would have considered going to the hospital." She waited 18 hours, and actually she had sudden cardiac death, and she's lucky, she's doing beautifully now, but she was like you, no risk factors.
Right. And not to brag, when I wrote down I'm a lifelong runner, even at the time of that test, I was still able, I could run 10 miles in a little over 6 minutes a mile. So I was a serious runner with
Yep.
moderate skill. And, and now I still, as I said, I worked very hard on the elliptical. I keep a little vial of nitroglycerin on the elliptical now, or when I go for a walk up hills. But haven't had any, probably psychological, that now that my LDL is 25, I haven't had any of those anginal signs. Or maybe I also know that I have sort of not critical stenosis, but I'm very happy that my LDL is where it is, and I'm waiting for the LPA drugs, although we've had a good response already. So
Henry, can I ask you, and there's a couple of great questions that have come in, but just for everybody out there, because most people on this call tonight have high LP little a or a family member with potentially high LP little a, and they are living with some degree of anxiety. When you got your first coronary calcium score, and the number wasn't that high, but it was the 90th percentile because you were a young man, were you anxious? Did it provoke anxiety, or did it sort of spur you to act?
It was surprising. It was quite shocking to think that I had that. But yeah, I guess knowing as much as I did already about LPA, I just took it as, again, a serendipitous good fortune event and decided to do something about it. It was pretty easy to say I'm lowering my LDL. And of course, now that I have a little bit of a reputation, certainly around New York, as the LPA, one of the LPA doctors, there are a few of us. We get a lot of people and who've read the New York Times or something like that and get an LPA done despite the hesitancy of their physicians, and it's high. And they might be, what do you do if you're a woman, you have a bad family history, you're premenopausal, you're in your mid-40s, your LDL might be 110, 120, 130, no one would treat that. And now you have an LPA that's 90th percentile, but it's actually a very low number. And it's important to know that, like everything else about risk, we have absolute risk and we have relative risk. And an LPA of 10, an LPA of 5, the score of 5 in a 45-year-old woman is probably the 95th percentile, because it should be 0. And in most men, it should be 0 at that age. But that's not a lot of calcium, and it's very unlikely to mean that something is going to happen to you quickly. However, we should really think about lifetime. And when a 45-year-old finally agrees to listen to me about going on a statin, they always say, do I have to be on this for life? And so I do some quick arithmetic and I say, you're 45, I'm only going to keep you on this for 55 years. And that's my standard response. So I do think, but I can tell you about someone I know who is 50, going to be 51 soon, and had a coronary calcium score of 1300. And now is undergoing a series of tests to see what's going on. So there are people at high risk. There are people at low absolute risk. Relative risk gives us the long-term risk in it. And since LPA is not going to change, and we're getting older, your absolute risk will go up, and you're still going to be ahead of the line, which is not a good place to be.
So a woman named Michelle wrote in and said she has a husband who had 4 heart attacks, and her boss was a pharmacist and recommended that her 8-year-old daughter be screened for a lipid panel. And her daughter had an LDL of 331. And then so she got into care. Her daughter's getting therapy. I'm assuming it's a statin, and has a cardiologist who she sees periodically. And Michelle, I think astutely, asked for her daughter's LP little a to be checked. And her cardiologist said, wouldn't change the treatment plan, so I'm not going to check it. Now, that might be being paternalistic, not wanting to worry her about something that, we don't have a drug for at the moment. But would you recommend that Michelle's daughter have her LP little a checked?
if her 8-year-old daughter, it's a tough call. I think I probably would have, if her LDL was over 300, and because she's 8 years old, she was on a low dose of a statin, and maybe her LDL is now 200, and now I have a high LPA, and if there's a family history, as there is, of really early and bad coronary disease, I would think of adding a drug like ezetimibe,
Sure.
or maybe if the child would tolerate it, Welchol,
Mhm.
and I would push the envelope a little bit. I don't have any sound evidence. We do have observational evidence from the Dutch, where they followed huge cohort of children for 30 years with monogenic familial hypercholesterolemia, with or without high LPA. And they compared them to the pre-statin era in terms of outcomes, and the outcomes are dramatically better over a period of time. Now, is someone who's just heterozygous for FH or just has a high LPL, no matter how high it is, are they going to have something bad happen to them? Other than the anecdotes, and we have to say this, it's the truth. There are anecdotes of young people, adolescents, who have strokes and are found to have very high LPA levels. Probably a few handfuls are known, but we're really thinking about the long run. And then it's a balance of how anxious do you want your child to be?
Sure. And Henry, we know we don't give medical advice on this on our webinars, but let me just ask you about aspirin. If you had a patient with a high Lp(a), would you who's never had an event, would you recommend low dose, Aspirin, a full aspirin?
I do, and I would say I know we all know the latest findings. We know what the preventive,
Oh, yes, we know.
recently about primary prevention and aspirin. And it's always hard to prove that primary prevention of anything works because event rates are low, the studies are too hard to do. And aspirin can cause bleeding. We know that as well. I would say that in this day and age, if I have someone with a high LPA, I will get a coronary calcium score. And if it's positive, they have coronary disease. They don't have clinical coronary disease. It's hard to say that I'm now treating them in secondary prevention, but it's not what I would consider to be primary prevention anymore.
Mm-hmm. Right.
And I think they all deserve to be on aspirin. Now, if they have a zero calcium, then I think I would take other factors, other risk factors they have, the family history. But I think that especially we worry about LPA being this prothrombotic, prothrombogenic molecule or package in the blood. So it adds to the need, I think, instead of aspirin.
And there's another question, and I think I read your AHA paper, so I know the answer. But asking, should people get genetically tested for LPA, or is the number, their level in nanomoles per liter or milligrams per deciliter, good enough?
So, as I said, yeah, the K4-2 repeat is so highly correlated with levels in the population that there's no reason to actually know that number. You know the LPA concentration, you know they have a lower number of repeats. Now, things may change because, as they said, that only accounts for about half of the genetic regulation. And now with super ability to do more deep sequencing and genetics, there are hundreds of SNPs, single DNA-based variations that change an amino acid in the protein that can raise LPA. So there are going to be LPA scores coming out, which the combination of those variants and the K4-2 repeat that might give a little more information, but probably it's just going to mean those people with those bad variants will have higher higher LPA levels than expected. And it may be, for instance, that African Americans have different types of these small variants or more of these small variants that add on to the K4-2. So for the same K4-2, they have higher levels. This is stuff that's moving rapidly. But right now, the level is, I think, all you need.
And you know, at these webinars, we always get this question. I mean, lots of people have heard, and there's lots of information out there about the negative effect of statins. And you mentioned it, you're taking a statin, that it can raise Lp(a) slightly, but generally not significantly. There's a question which we would have expected, should you take something other than, so I'm assuming, should you take ezetimibe, a PCSK9 inhibitor, bempedoic acid?
So, I mean, I certainly, again, if I have someone who's come in and they have an LDL of, well, if they have coronary disease already, and they have now, we found they have a high LPA, with coronary disease with and low LPA, I would still want my patients to have LDLs of 50. If they have a high LPA, I'd like them to have LDLs that, like I have, 25 or 20. So if I have them on, if they're on a statin and their LDL is 60, if I add ezetimibe, you know, I get them down to 50 to 50. But, and there's no, I haven't done anything to their LPA. If I get them on a PCSK9, then I'm going to get their LDL to 30 or 25 and hopefully get a 20 to 30% reduction in LPA. So it's the best second drug to use. However, you've got to go up against the insurance companies. You've got to get write repeated letters, and you know, it took me 3 letters from my nurse practitioner to get approved. And so, but I think hopefully that will dissipate, and the barrier will fall, or the prices will come down. But certainly that would be the best second drug to take. Without that, if you did ezetimibe, as I said, you'd get a good LDL lowering. If you added bempedoic acid, and that's not much less expensive, I think, than a PCSK9, you'll get another 20%, but none of those are going to affect LPA.
And I'm just looking at the time. We only have 2 minutes left, and it's obvious that you were a hit because so many questions were asked. I just have a few slides to go through before we end, and I want to thank everybody for their great engagement. So I want to encourage people to go to the Family Heart website. Next slide. We have lots of resources. We have infographics that you can download on Lp(a). Next slide. We have information that is easier than clinicaltrials.gov to go and find a trial for lipoprotein(a). As Dr. Ginsburg said, there are multiple trials going on. The pelacarsen trial is fully enrolled, but there are other trials. Amgen has a drug, Silence Therapeutics, and Lilly has got an oral agent, but it's in very early stages now. Next slide. If you have high Lp(a) and have questions, you can visit our Care Navigation Center. We have a care navigator who is Stanford trained, an excellent scientist who can help you and work with you and answer some of your questions. Next slide. You can become a Family Heart advocate for awareness. We have training sessions every year for advocates where they learn a lot about Lp(a) and a lot about familial hypercholesterolemia, and we'd love to have you be involved, raising awareness, sharing your story, providing peer support, contributing feedback, and fundraising through some of our Race for FH and Lp(a) and that kind of thing. Next slide. And you know, we are grateful for everybody who donates. It is what allows us to do what we do, to reach all of you, and so we appreciate that when you donate. Next slide. And please feel free to contact us. We're here for you, and we're here to answer your questions. Thanks very much for joining us.